Kia ora everyone and welcome to our Goodfellow webinar on update in contraception. My name is Dr. Courtney White and tonight I'm talking to Dr. Helen Paterson, a senior lecturer at the University of Otago and who sat on the New Zealand Contraceptive Guidelines Advisory Group.
Kia ora koutou, ko Sagamartha Tumonga, ko Waitati Te Awa, ko Otipoti at Aho, ko Helen Paterson toku ingoa. I'm a senior lecturer at the University of Otago and I really was asked to come and speak here for you as a member of the National Contraception and Guidelines Steering Group. And what I'm going to be discussing is really just to get you all on the same page with regards to the guidelines which were produced last year. But I've got a couple of other things that I just want to highlight as I've been discussing this area with people prior to giving this talk that people brought up as being important and missing from the guidelines. So first of all, just thinking about what's important. This is where to find it. So if you Google contraception New Zealand MOH, then you will find this, and this is the page you're looking for, and you want to be just downloading the PDF or the Word document. What do you need to know? Well, one of the things you need to know is actually not in the guidelines, but it's about abortion law change, which also happened last year. And it's around conscientious objection and conscientious objection with regards to contraceptive services. So essentially, law change has occurred such that as someone providing the service, you must tell them at the earliest opportunity that you are a conscientious objector, and critically how to access the contact details of a person who is the closest provider, and you must consider at the time with regards to that. So for example, if you had someone presenting wanting emergency contraception, you need to tell them the closest service provider that they can access, let's say on a Saturday. So that's sort of quite an important change. Thinking back to the guidelines, which is mostly what I'm going to talk about for the rest of this session, their basis, they come from the UK Faculty of Sexual Reproductive Health contraception guidelines, which were been around for quite some time, and they've been adapted to the New Zealand situation, and they should now be considered the best practice guideline with regards to contraception in New Zealand. So what might be new to you? Well, the first thing is thinking about gender and identity, and so obviously this applies to all of our care, but being really positive about how you're using pronouns, ensuring that you've got your gender identified and that you're an inclusive in this area, and thinking about how that applies when it comes to contraception. It's very important for someone who is transgender male, it's a trans man who is still going to need contraception, as testosterone doesn't give them contraceptive cover. Most commonly, progesterone-based contraceptives, so not estrogen, not the combined pill, are what people are going to find acceptable, and so just knowing that and knowing how to go about it. Next, talking about tiered counselling and shared decision making, it's really, really critical that the person you're providing contraception to is involved in that decision making, and that they don't feel like they're having to make this choice because of what you want rather than what they want. So obviously that's a skill that a lot of people who are working in primary care are very good at in other things, but it's really, really critical when you're having a conversation about contraception. And I think particularly when it comes to pregnancy and abortion care, ensuring that we're not placing people under pressure to choose a particular method of contraception or a contraception at all. It's got to be what's right for the person that we're looking after. It's essential that when we're talking about contraception, we think about what actually matters to the person. So we need to establish that from them. Often they'll have had prior experience and they'll be able to tell you what they do and don't want. But what's also really important is that when you're presenting the method, you present from the most efficacious to the least efficacious. If you ask people what they want when they're seeking contraception, the majority of people want to not get pregnant. And that seems like a really obvious statement, but the most common contraceptives that are provided in New Zealand are the combined oral contraceptive pill with an 8% failure rate first year of use, which if you extrapolate that out, could be up to 60% by the time you get to 10 years of people having an unintended pregnancy. And condoms, which are even worse. Awesome, definitely should be providing them at prevention of STIs, but we should be using them alongside other forms of contraception. So I'm now going to talk about long-acting reversible contraceptives. For a lot of you, I'm sure this will be sucking eggs. You've already know everything about it. This is a table that's taken straight from the guidelines. I find it very upsetting that it should be the other way up, because the implants should be at the top. They are the most effective. The failure rate's 0.1 for years 1 to 3, 0 at year 4, which really just means that that's within statistical error, but it goes up to 0.8 for year 5. And that's really critical when we're thinking about counselling people. And this is where it comes into the guidance with regards how long do implants last for. And when we think about weight, and we know that there's higher failure rates with people who weigh over 70 kilos. If you've got someone who's got a situation where the risk of pregnancy is a risk to their life, you might want to be changing their implant at 4 years, not 5. If you look at the others, you're still looking at failure rates under 1%. And so that's what we're really defining as a LARC. It's something that's reversible and effective. So why are we not using more LARCs? The rates reported are around about 8% in New Zealand and Australia. And there's a lot of myths out there, an awful lot of myths. Essentially, you can pretty much use a LARC for everybody, as long as it's something that they want and there isn't a specific contraindication to that LARC. There will usually be one that is effective for them. And it's not a contraindication to use intrauterine contraception in young people or in people who have not had any pregnancies, which has been believed before. So really want to point out that if you think about efficacy, tubal ligation's got a 0.5% failure rate as a generally accepted quote that's outside of pregnancy. So actually, most of them are actually better than that. And that's why we may be recommending using LARCs instead of using tubal ligation as an option for contraception. Really important, and something that I think has been missed, we have different types of copper IUDs, and the copper IUDs that have copper on the arms, so not the loads, the old multi-load type that was the only thing we had for some time, and a lot of people seem to be comfortable inserting, they are not as efficacious as the CU 380As. So what you really want is the ones that have got copper on the arms. And you must know that that insertion method is different for them than it is for the others. But still, they're the best thing to be using. There's no evidence that you need to clean a cervix before you put an IUD in. We know that the bugs that are there can go up through the mucus plug when we put the IUD in, but cervical cleansing doesn't have any evidence to say that it reduces that. And with regards follow-up, it's really critical. You can put in an intrauterine device in one visit, and you don't have to see the person back, but it's got to be tailored to the person. So it has to be what they want, and you have to follow them up as is indicated. What's really, really important is they're fully informed, that they can check whether they've got an expulsion, that they can check whether they've got a perforation. and that they know that if they've got abnormal symptoms, then it's really important that they present. Menstrual cups, tampons, not a problem. Just make sure that they know that they don't pinch the strings and pull it out at the same time. I've been ranting on about PID for about 20 years with regards to IUD. There is clear evidence to show there's an increased incidence of pelvic inflammatory disease in the first 20 days after insertion of an IUD, but there is no evidence of it other than that. And so therefore, if someone doesn't have a known sexually transmitted infection, you can put an IUC in and you don't have to worry about PID. If they get PID, then you need to treat it, but you don't need to take the IUD out unless they don't get better. And so that's really critical in terms of going forwards. The data from the CHOICE study showed a 0.22 risk if you didn't have chlamydia or gonorrhea. Still a less than 1% risk even if you did. So it's not a high risk. When we start to think about pregnancy with intrauterine contraception, it's really important to know that if you get pregnant with it, there is a higher risk that it's an ectopic pregnancy, and that can be really quite a significantly high risk. So it's important that you go looking for where that pregnancy is, but that overall there is not an increase in ectopic pregnancy. So prior ectopic pregnancy is not a contraindication to using it. It's just that you need to know that it doesn't stop ectopic pregnancies. Thinking about things that are really might be new to people, and then this has been some guidance that they've put out with regards to when do you remove. Particularly, this is talking about IUCs again. So if you've had your IUC put in before you're 45, then if you've got one that lasts for 5 years, you're going to have to put another one in. But particularly this bit around women who are over 45, it can rely on Mirena for up to 7 years. So this is a critical difference. And one of the things we're finding is these people who are having Mirenas taken out that have been in for 5 years, they're 52, and they don't know when they had their last period because they're amenorrheic on the Mirena, and then they take it out and 4 months later their periods come back and they're just absolutely devastated. So GIBO recommends just leave it in until 56. So it's the UK contraceptive guru. We have to obviously balance the efficacy of the contraception over the fecundity of the patient, and by the time you're 55, you're not likely to get pregnant with or without an IUC in, but certainly even a bit of plastic is going to help you not get pregnant. Right. So next, moving on to contraception after pregnancy. I'm sorry if I'm going too quickly, and I'm not just reading the slides because I don't want to be boring. Right. But basically, what is critical is that when we're talking about contraception in pregnancy, you should be counselling people antenatally, ideally in the second trimester when they're feeling well, and you should be talking to them about their contraception, deciding what they want. And then we need to get really good at ensuring that we provide that contraception for them. And there's a study called the Apple study run in Scotland where they did this, and only 9% leaving the hospital had the contraception that they wanted before their birth, because we weren't doing a good enough job of providing it. So we can insert IUC at the time of birth. It's not commonly done in New Zealand, but it is more common elsewhere in the world. So immediately placenta out, IUC in. It's got a higher expulsion rate associated with it, but actually if you look at 6 weeks, there's more people with it in situ. But it's really important that you must have a follow-up and you must have community education around that. It's not something we should just be doing as, one-offs. Otherwise people won't know why there's long strings. They'll pull them out. People with missing strings won't be able to access ultrasound to be able to see whether it's in the uterus or whether it's fallen out. So we really need a whole program of insertion if we're going to start doing this. But implants are regularly inserted postpartum, and that's absolutely fantastic. They work really well. There's no contraindication for breastfeeding. The thing that we've got to remember in the New Zealand context is that you get it freely placed at the hospital, but implants actually have a cost when it comes to having them taken out. And at that 0.8% at 5 years doesn't mean that at 6 years it's not doing anything. So we've really got to be cautious about our informed consent and telling people all the information that they need. And it must be accurate, and we mustn't be pressuring people to choose particularly Jadels if we haven't got a plan in place for them to actually have it removed when they want to plan their next pregnancy. We've not got great accessibility to all our contraceptive counselling leaflets in multiple languages, and we need to get better at that. So moving on, thinking about Depo-Provera. So Depo, this is outside of pregnancy. We're talking about a use failure rate of 3 to 6%, depending on which data you look at. So we don't class it as a LARC because it's not less than 1%, but it's better than pills, patches and rings, which are sitting at 8% failure rate. Remembering the delay of return of fertility. So it's really important that if people are not in a situation where they know that they're not going to want to get pregnant, you're going to have that conversation. Are you planning pregnancy in 2 years' time? Okay, but anytime in that 2 years, maybe you want to think about something different, and informing them, because they're going to have to wait till then get fertility investigations and treatment for 2 years after their last depo. And then there's a recommendation to consider something else at the age of 50, and this is around the fact that we know that depo causes a dip in bone mineral density and around having time to actually recover it, which you do recover it once you stop it. There is a concern with depo around body weight increase, and so people who are gaining more than 5% of their baseline body weight are more likely to carry on gaining weight, and these people should be offered an alternative. And then my one big bold one is a big change that's in the guidelines, which is the change from 12 weeks to 13 weeks in terms of repeat injections. So that's pushing out the length of time, so not having to have your depo quite so frequently. And that does actually impact, when over time, yet ending up having less appointments, less cost. So that's a big recommendation that's come out. And up to 14 weeks after the last injection without additional contraceptive precautions, but noting that that is outside of the product license. I have one slide on combined oral contraceptives. I talk about tiered counselling and the fact that we should start with the best. So the combined oral contraceptive pill, most commonly used contraceptive in New Zealand, has a failure rate of 8% per year. It was just in the recent health quality safety showed that 14.8% of women aged 10 to 54 would dispense the pill at least once. There's a disparity in terms of who are being prescribed it, which varies massively across the country and also across ethnicities. And I think we really have to challenge ourselves to do better at ensuring that the reason why someone is using the oral contraceptive is because they want to use it. And I have no problem with that. That is absolutely fine. But it must be because it's their choice, not because of our choice. And the reason why I say that is if we look back at, and I just had 2016 data easily available to me, but 9.4% of people who had abortions were using the combined oral contraceptive pill at the time of them getting pregnant. and as I say, I don't have a problem with it if someone's chosen to use it. That's absolutely fine as long as they were fully informed. But it should be something that is being driven by them, not being driven by us. Emergency contraception is really quite critical, because the other large thing we use as contraceptive is condoms. And one of the things about the emergency contraceptive is that this actually relates back to LARCs again, because the most effective emergency contraceptive is the copper intrauterine device. There's some research being done looking at Mirena, but we're not there yet in terms of having that as a recommendation on the data sheet. But it's definitely an area that we should keep our eyes open for. And the reason I say that is because a lot of more people want to have a Mirena, and so therefore might choose to have it put in at the time of emergency contraceptive if it was as efficacious. Whereas with copper IUDs, because they don't want to continue using them, they then don't want to actually have them as an emergency contraceptive. And this is really just related to the 94% reduction in blood loss with Mirena and the number of people who will end up with amenorrhea versus to the increased heavier bleeding with the copper IUD. However, some people are going to love it because it's got no hormones in it, and it's a good and effective contraceptive. So if someone presents needing emergency contraceptives, the first line choice should be to offer them a copper intrauterine device. However, we all know that what's going to happen is people are going to pitch up to the pharmacy, or they're going to get dispensed emergency contraceptive pill, or in my dreams they're going to have got given it already and it's already in their cupboard. So then we need to tell them how efficacious it is. And so we haven't done a randomized control trial where we say, oh, we'll just go off and get pregnant versus here, I'll give you this pill. So what we're doing is we're comparing efficacy with those people who took it at under 24 hours, which we're considering as the optimal, and later. And so 0.7% pregnancy rates in people who took it under 24 hours and 1.6% by 96 hours. So essentially, although the numbers vary really due to statistics, but basically the further away you took it from the time of unprotected intercourse, the less efficacious it is. So the best place for your emergency contraceptive to be is in your bedside drawer. So you have sex, you go whoops, and you take your emergency contraceptive. They don't work after ovulation. This seems to have been something that's been massively missed. So they're just not efficacious after ovulation. That's half the cycle. So you know, the person who comes in at day 21, there's no point in giving it to them. Copper IUD though, you've got to think about where you put it on in the cycle, and you can insert it for up to 5 days after the first unprotected intercourse in that cycle, or up to 5 days after the earliest likely date of ovulation, whichever is latest. So you get a little bit more leeway there. The other thing that you have to think about with the emergency contraceptive pill that we're all discussing is how beneficial is it to take an extra dose? So we know that if you weigh more than 70 kilos, then there is a reduced efficacy with the oral contraceptive. Actually, for most of our hormonal methods, we see an impact in terms of weight. But does doubling the dose actually make a difference? And the answer is we don't really know. There's very little data out there. But what we're saying is, well, it's probably better than nothing, because we do have some data to show that you get up to the same serum levels if you weigh over 70 kilos and you take 2 tablets, so 3 milligrams versus 1.5 milligrams. So that's important. It's really important if you go into the pharmacy, because you can have to pay double the cost for it. And most people in New Zealand actually do weigh over 70 kilos. So this is a really critical thing that we need to be thinking about when we're thinking about funding, and we know that there is really inequitable funding for emergency contraceptive across the country. Let's think about barrier methods. So first of all, really there are no diaphragms in New Zealand effectively. There's one that has been able to be purchased, and the description that everyone gives me is it fits no one. It's supposed to be a one size fits all, but it's actually a one size fits nobody. If we look at condoms, absolutely we should be using condoms, but we must be thinking about dispensing emergency contraceptives alongside the condoms. So you can have them on PSO and dispense them, but you can also prescribe them when you prescribe your condoms. Condoms obviously critical for prevention of STIs. So what's missing? Well, one of the things is training. I've just been talking about LARCs sort of non-stop the last half an hour, and we know that there is a problem at the moment with people getting trained. So the ministry are working with the colleges and trying to develop a training policy for LARCs and a training policy for being a trainer of LARC insertion. And I'm really hoping those will be out in the next, well, certainly by June is my hope. In the meantime, these courses are on Family Planning website, and there's 4 courses that have been developed. So there's the contraception counselling, which is available widely, and then there's training for intrauterine contraception and contraceptive implant, so LARC insertion removal training online, and then there's a trainer and assessor package for being a trainer. These are all online learning, and we recognise that this isn't a see one, do one, teach one. This needs to be an organised package of learning where you have the theoretical learning, and we're all learning the same thing, we're all talking the same language, and that people are then being assessed and trained in real life situations. So it's not how to do it on a model arm. And so that's coming, and so will be with us shortly, hopefully. The Family Planning website is the place to go if you want to register for the contraceptive counselling training. The others are very much DHB, so you have to get approval from your through your DHB, and this hasn't quite got resolved yet, but hopefully there will become more wide access to them soon. And I'm hoping that everyone who is putting in LARCs will actually go and do the modules, because I think it's really important that we're all on the same page, and we're then all talking the same language when it comes to insertion levels of LARCs. We know that when we look at insertions of IUDs, they're obviously it's more complicated than removals, and it's the other way round with regards at implants. If you're putting in implants deep, if you think it's a subcutaneous implant, not a subdermal implant, then you really need to think again and go and do your training. And I think that if we get people doing the online training, then they might work out that actually they need to go and get some more practical training as well, to ensure that they're actually providing best care. And then finally, with planning this talk, I had quite a few people start to ask me about terretogenicity, and this is completely missing from the guidelines, really. The UK do have, in their FSRH, they have a guideline. And ACC last year came out with some information, particularly looking at anti-epileptics and especially targeting sodium valproate. So the guidance from the FSRH is that if you've got a drug interaction that you want to know with regards contraceptive so, you know, can you be using it with progestogen, for instance, or is it going to impact on the efficacy? Then you really want to go and look at Stockley's, so look at the NZ formulary to manage those drug interactions. And the reason why we're saying that is because there's so many new medications that come along that you can't just list them all in the guideline. What we need to be doing is best practice, which is what we would be doing for everything. But it is really critical that someone who's on a medication that's teratogenic is given optimal contraception. And we're back to LARCs again, and with a less than 1% pregnancy rate and the fit and forget nature to it, really we're looking at intrauterine contraception as being efficacious and not impacted on by liver enzyme induction, versus implants, which are fine for someone who is taking teratogenic medicine that doesn't interact and cause liver enzyme induction, and thus increased metabolism and a reduced efficacy. In that situation, that's not an acceptable option. And so the FRSH statement is that either it's a copper intrauterine device or LNG IUS, or male or female sterilization, or which have a less than 1% failure rate, would be recommended. ACC statement is that we should prescribe 2 effective methods, and I think the debate we've got here is what's effective, and I don't think that something that has a 13% failure rate in the 1 year is actually effective. So we really need to think about how can we do this better going forwards. So all the numbers that are referenced within my talk all come directly from the guidelines and are in the guidelines. You can go and look, and the references are in there. Otherwise, I've referenced in the document as we've gone along. And I'm happy to take questions now.
Helen, thank you. That was an excellent overview. So a few questions have come in. Do you have any advice for people prescribing the combined pill with women who are obese?
Well, so I think fundamentally my advice is I wouldn't prescribe it. So you need to go and look at the FSRH medical eligibility criteria. And you have to do it for each individual person, because often they, particularly people who have got an elevated BMI, they will have other contraindications as well. And so it's really important to go and look at that. I find the FSRH MEC quite difficult to navigate, and I much prefer using the WHO app. And there's no problem with that. So you can download the app on your phone, and then you plug in all the problems that the person's got who's in front of you, and it comes up and tells you what you can and can't use. And I think that's the best way to go. And often it will say, actually, we wouldn't be recommending that you're using the combined pill because of the increased risk of cardiovascular disease associated with it, and particularly VTE. But it does depend on the person. And what we've always got to remember is that using no contraception is actually going to result in higher risk if someone gets pregnant. So if someone doesn't want to get pregnant, and the only thing that they want to use is the oral contraceptive, then you're balancing those risks and benefits of pregnancy versus the oral contraceptive. But I think it's very much on an individual basis that you have to manage that.
Further question on the pill was any further advice regarding the combined pill and migraine without aura?
So the recommendation is focal migraines. You shouldn't use the combined oral contraceptive pill, and that's the contraindication, not with non-focal migraines. And there's some nice, if you go and look at the guidelines, there's some information there which you can use in terms of guiding you. But again, that using the MEC criteria. If we want to talk about focal migraines, that's a little bit more complicated, and they're very clearly a MEC 4 in everything, despite the fact that the evidence actually comes from increased stroke risk associated with high dose, so 50 microgram pills, which we've just pretty much got rid of in New Zealand. And so if you talk to neurologists, they will tell you that, my understanding is that they do not believe that migraines are vascular spasm related, and they question our whole theory and hypothesis with regards to the pill and migraines, but it's still very strongly with the WHO and the FSRH as a MEC4 if you've got a focal migraine.
And still on contraceptive pill, would you have any recommendations for women with polycystic ovarian syndrome, any particular pill?
So this depends what you're treating. So if you're treating someone for contraception, then you should give them tiered shared decision-making advice about contraception, and that optimal management for people with PCOS, if they've got heavy bleeding due to irregular ovulation, will probably be a progestogen base, often the Mirena. If you've got, and that's going to protect them long term against getting endometrial cancer, because if they've got irregular bleeding, you need that progestogenic protection of the endometrium. Mirena gives you a 60% reduction in endometrial cancer. So you definitely want to be thinking about that. If you've got someone who only wants to use the pill and doesn't want to use something that's more efficacious and potentially more beneficial for them, then you have to ask why. And often when you ask them, they will say, well, because my friend's acne got better or their hair growth got better. And so they're not actually wanting the combined pill. They're not actually asking for Jeanette. What they're saying is, I want contraception, and I don't want to have this excess hair. And when you have that conversation with them, you can then say, well, look, if you have a Mirena, which is highly efficacious, I can then prescribe you whatever the other thing is that we need to give you. For example, cyproterone in Jeanette, or spironolactone if you're thinking about other forms of so drospiridone type progestogenic effects. And then you get effective contraception and you get effective treatment of their hair growth and acne. So I think you have to pick it apart for them and work out what it is. But if you're going to prescribe them Jeanette, then you need them to know that they are significantly increasing their VTE risk in comparison to using a normal Levelin. And often they will have a higher BMI. And so you're then really increasing their risk, and they need to be fully informed about that. So I generally try and convince them to just start on Levelin, and often they will find that that's enough. But I have the conversation with them about what do they actually want, and then I have to say the majority of people I care for, which is a very different population, will end up using a Mirena plus some management for their elevated testosterone.
A couple of questions around infection screening prior to IUD insertion. And if you are swabbing, do you also check for BV and thrush? And do these need to be treated before you put the IUD in?
So BV and thrush don't need to be tested for unless someone's symptomatic, and they certainly don't need to be treated. If you know someone has chlamydia or gonorrhea, or are highly suspicious that they do, then the recommendation would be that you treat before putting the IUC in. If you see someone who is not high risk, and you don't see a frank cervicitis, or you're not concerned about it, then you can swab them at the time and then treat them if they come back with a positive result. But yes, if you've got a swab that says this person has chlamydia, then I wouldn't recommend that you put an IUC in until you've treated them.
Mm-hmm. What would be the youngest acceptable age for an IUD?
Well, the youngest I've put in is 12. I have, so people who are pre-menarche and they're usually got an intellectual disability, and mum says, I really want them to have the Mirena because I don't want them to ever have a period, the recommendation is actually you wait until they have their first period. And often they actually cope with it better than mum thought they were going to, but if they don't, then you put it in. And the reason for that is, one, you don't know when they're going to start it and when they're going to go through menarche. So you know, it might be a number of years, but two, you want the uterus to be a big enough size to actually put a Mirena in, because a GDS is not really effective at creating the amenorrhea that you want, so you need that uterine cavity to be big enough. So that's the youngest side of things. I guess the other question that we're asking is, you know, do you put them in people who are not sexually active? And yes, so my big thing is someone has to want it. I will not put an IUC in for someone who doesn't want it. And I find that people who want it, no matter what their age, cope very well with it. And the people who don't want it, the people who you coerced to some minor degree into having it, they're the ones that don't tolerate it well. So, you know, I did a clinic with a shearing gang a few months ago, and highly motivated people who really wanted stuff, they put up with anything. There's just not an issue at all with it. The 14-year-old who's got heavy periods, who's not sexually active, who when you say, what do you think about having a Mirena, they go, yeah, they're not the person to try and put it in. And if you really have to, that's the person who might need a general anaesthetic. But the one that says, hey, I'm planning to have sex in 3 weeks' time and I want to have reliable contraception, and I've been reading about this Mirena and I really think it sounds like a great idea, yeah, they'll probably be absolutely fine.
In women who haven't been sex active before, but you are inserting an IUD, would they be at high risk of like a cervical shock during the procedure?
So loads and loads of people say to me, it'll be much more difficult in nulliparous women and in never sexually active women. And I have to say that, I mean, I know I get referred the difficult people otherwise. By far the hardest people I get is the, you know, 3 births, cesareans, retroverted uterus, endometriosis. They're the ones I worry about. And I don't worry about the 14-year-old who's never had sex at all. You do have to put the tenaculum on very carefully, and they do have they tend to have a pretty small cervix, which is easy to traumatize. So you have to be gentle. But I mean, I would say that for all my IUC insertions. So I put a tenaculum very, very slowly. And that gets rid of the pain that's associated with putting it in. Just be very patient. And I may use a cervical block if I've got someone who's a little bit anxious but still really wants it. And I think that so there's not a lot of data to show that it reduces cervical shock, but there's certainly some anecdote out there that people talk about it with. So that's probably the time when I might do something a little bit different. But generally, I don't worry about it. Just go ahead normally.
Just a couple of people wanting clarification on that app that you mentioned for contraception.
Yes, so it's the, hang on, I will find it on my phone. It's looks like that. Can you see it? All right, it's all negative. So it's the medical eligibility criteria for contraceptive use, WHO. And if you look that up, it's certainly on Android. And it's got an eligibility tool, and then it's got a whole list of different things that people have got, and you basically you know, you can pick which drugs they're on, and then you can pick what they've got, and it changes the recommendations down the bottom on a list of all the different contraceptives, and it's fantastic.
Any advice in terms of the annoying bleeding that a lot of women seem to get on the Giselle?
Yes. So when I put Jadels in for people, I very much counsel them about this. So really, really important that they know about it beforehand. And if they know about it beforehand, then the kind of light bleeding that's not really that problematic, they might actually cope with fine. But I also give them a plan. So it does depend on their risk profile. We know that if you give people 3 months of the combined pill, if they've not got a contraindication to it, and you can use a low dose, then you actually both reduce the bleeding during the time that they're on it, but also you get a reduction afterwards as well. So they seem to end up in a better situation afterwards. But the other thing is using non-steroidals. So whilst they're using non-steroidals, it reduces the bleeding. And so particularly the person who says, well, it's okay a lot of the time, but I want to be able to go swimming, or I don't know, I'm going on my honeymoon, or knowing that if they take just literally ibuprofen, it doesn't have to be more complicated than that. And often they have to check they have to work it out themselves what dose they need, but often 200 milligrams 3 times a day might be enough for them to just stop that spotting. So I don't see it as a problem. I've got an effective contraception. If I ended up actually having them on the pill, low dose pill, for the whole of that 5 years, if they didn't have a contraindication to manage their bleeding, then I wouldn't see that as a problem. And I certainly wouldn't say, okay, well, you've got abnormal bleeding, so let's take your Jadel out and then put you on the pill, where we just gave you over that period of time a much higher risk of pregnancy. So just leave the Jadel in there and just leave them on the pill as long as they've not got a contraindication to it.
And if they do have a contraindication, of course we can use ibuprofen, but is there any place for something like Provera?
Yeah, so there's very little data for Provera, but try it and see. So family planning recommend it. Very little data to show that it does or doesn't work. Like there's just no, I'm not saying it doesn't work, there just is no data out there. Nobody's published the studies. So give it a go. One of the problems is, so the person who's having heavy bleeding, then you can manage that just like you would do your own heavy bleeding. So TXA, Provera, that's fine. But if you've got someone who's just having that light bleeding, they might actually have a really, really thin endometrium. And so then if you give them more progestogen, it just doesn't help. So the light spotting often needs that bit of estrogen to stabilize it. So then one would argue, don't use Provera, use norethisterone, but then you've got to wonder how much is their contraindication to the combined oral contraceptive pill, and actually is norethisterone with its slightly estrogenic effect gonna also be contraindicated for that person. And maybe in that situation, you just need a Mirena.
Yeah. So some questions about bone density and the depot. Is there any kind of time limit, for example, that young women should be on it, say teenagers? Any limit on sort of length of time in general they should be on it?
So all of this is kind of based on best practice advice, and you can go and look, and there's a whole lot in the contraception guidelines. But what you have to think about is what's going on physiologically. So ideally, we want people to get to their peak bone density before they start their depot. They then will have a dip with their depot, but when they stop it, they will return back to their baseline. But we want them to have a chance to return back to their baseline before they then start to decrease at the end. So that's the way to think about it. Equally, we're not saying that depot has catastrophic effects on bone mineral density that are awful, and it's always a balance of risks and benefits. And there is some useful guidance to go and have a read of in the contraception guidelines.
What is your advice for people who say they don't want something foreign in their body? This person predominantly works with younger girls and women. Yeah,
so what I find is there's two aspects to this. One is a misinterpretation about menstruation. And so the reality is that they think that they should have periods, and they don't want anything that's going to impact on them. And so I explained to them that if you went back 200 years, it was normal to be pregnant, lactating, or dead, and that in actual fact, you would have had on average probably about 40 periods in life, not 400 periods. And that having periods is not normal, and that possibly explains a lot of problems that we have. And you know, we know that menarche has actually started earlier as well. And so actually, we not having periods is much more normal than having periods. So that I get over that myth by explaining that to them. And I find they take that on board really, really well. And then they go, oh, okay. So it's not all collecting inside of me. Nope, it's not all collecting inside of you. You're not going to explode. And it's good for you not to have a period. Okay. But I don't like the idea of having something inside me. Right? You're like, okay, well, what do you feel good about? What do you think would work for you? Right? And then they say, well, you know, and the condoms are okay because they're on him. But they're still inside you, right? Whilst you're having sex. Oh, yeah, I'd never really thought about it like that. But then they go away again. Yeah, that's okay. But then they leave a baby inside, right? It's 13% of the time. And oh, I don't really want that. So what else would you like to think about? Well, I might take the pill. Okay, that's absolutely fine. You can take the pill. We just need to remember how we're going to take it. Are we going to remember to take it every day? And that you're still taking a pill with some hormones oh, I won't remember to take it every day. Okay, so what are we going to do next? And I just work my way up. And usually by the time I get to the end of the conversation, they say to me, oh, so are you telling me I should have those rods? And I'm like, no, I'm telling you should have what you want. And what we need to do is make it work for you. But you need to understand what the reality of all of this is. And I absolutely never push. I think it's really important. It's got to be someone's choice. I never push them. I just give them the information and I'm honest about it. And when you get honest about it, then they go, oh, okay. And then they have their IUD.
Just a further question in terms of depot timing. So the new recommendation is now 13 weeks, not 12. What is the shortest interval you could give it to someone, for example, if they're getting the bleeding?
So they have got a statement in there around the 10 weeks. So that's sort of where they're sitting. Look, there isn't really a lot of data on what the shortest is. And if you think about what we're doing, we're giving you a truckload of dose. And we all know anecdotally that, especially at that beginning, you know, sometimes it seems that you give it and that bleeding gets better. Who knows? Maybe it was going to get better anyway. It makes us feel better because we did something. The huge effect of placebo of having a big jab in your butt. But, you know, probably 10 weeks is the answer to that. Equally, there are those occasional people who you come across who tell you that their bleeding always starts at a certain time. And in those people, I would say if they want to carry on depot, then give it before that time and what that is. But usually that's sort of around about at the 11-12 week mark. I don't usually find it's earlier than 10 weeks.
And just some questions coming through about the continuous taking of the combined pill now. Are there any kind of downsides to that? Do we need to recommend a withdrawal bleed every however much for endometrial protection?
So you're getting endometrial protection because you're taking a progestogen. So you're continuously taking a progestogen. So if you did an ultrasound on these people, they've got thin endometriums. When you stop it, they have a very light bleed, and that's because they've got very little endometrium there. So the recommendation is twofold aspect of things. So one is around the bleeding, and we know that if you take it continuously, you get less bleeding. And then the other is about, so that's my recommendation. The other is around efficacy, and we don't have an enormous amount of data, but logically, if you're taking it all the time, then we will have better efficacy because we know we can stop it for 7 days. So don't stop it, because the more you stop it, the more impact you're going to have in that way. If we look at hormone dose, we know that for 5 years after being, so if you've been on the pill for 5 years and you stop it, you get back to your baseline breast cancer risk after 5 years. And there is some discussion as to whether that extra week of taking the combined pill, it actually is going to impact on that. Well, one is use low dose pills, right? So if if you're using a 20 microgram pill versus a 35 microgram pill, well, that week is already not extra hormone, and often if you're using it continuously, you can do that, and they'll tolerate it really well. But the other thing is that you do go back to your baseline. So really, that's only actually an increased risk if you're looking at people who are high risk for having breast cancer. And if you look at people who have BRCA, who are obviously at the really high risk for breast cancer, because they've also got an ovarian cancer risk, and taking the combined pill for 5 years, it halves your ovarian cancer risk, and it does actually even lead to a reduction in risk for people who've got BRCA. Then it's a risk benefit analysis that you're looking at. And so overall reduction, there isn't an increase in endometrial cancer risk because you've got progestogen you're taking all of the time. You're ending up with a thin endometrium. No reason why you have to have a break at any point in time.
For those that are going to prescribe the combined pill for those with jadal bleeding, how long would you usually recommend?
I usually give them, so I usually dispense them 3 months worth, and then say, try it, and if it stops, and if it doesn't come back afterwards, great. If it does come back afterwards, then just come back and we'll just, and then my comment about dispensing of the pill, and I'm preempting some research that we're doing, so I don't have the answers yet. But we know from the US, the more pill you dispense, the lower the pregnancy rate. So don't prescribe 3 months worth. Prescribe 6. We're allowed to prescribe 6 months of the combined oral contraceptive pill. It's not a high-risk drug to have sat in your cupboard. If someone takes it, it's really unlikely they're going to have an adverse effect. So having 6 months of it sat in your cupboard, which means that you don't run out, is got a benefit which way outweighs the risk of having it sat in the cupboard, I think.
Would you recommend using a low dose combined pill for someone with, say, the spotting on the Mirena?
So actually with the Mirena, it's I tend to stick a patch on for them. So I tend to give them Estradiol 25 micrograms. I don't know why I do that versus giving them a pill. And I don't know why I do that, and I don't do it for jadal. I think it's probably that the jadal population are younger, and the pill is more acceptable to them as something to take. Whereas if I ask them to put a little sticky on the belly, they're going to feel like they're weird and they're odd in comparison to their friends. And plus they're going to go swimming. Versus the 45-year-old woman who her friends are actually got the little sticky on their belly, so they think that that's normal. And so that's normally the way I go, but that's literally just, there's not an absolute answer about it, but yes, a little bit of estrogen, absolutely, for that light spotting, and there's no reason why you couldn't do that with jadal as well.
A couple of questions about IUD insertion. Any use using something like lignocaine gel at the os when inserting?
So the data around lignocaine use with regards intrauterine contraception insertion is quite poor. I think when you use the gel at the os, what you do is you create a nice lobe. I don't think you do anything analgesia wise, but it slips in easier. And sometimes if you put the catheter gel tip on you and you use it and you just gently squeeze it in, you open the internal os. And so you get, what you're actually doing is physically dilating the internal os and then helping yourself slide it along. I don't think you're actually giving any benefit in terms of analgesia. And even lignocaine in a paracervical block, it does help pain for cervical dilatation, but it doesn't impact on the actual IUC insertion. And when you touch the fundus, it doesn't impact on that at all. Now, the data around prilocaine is better. So prilocaine does reduce insertion pain, but prilocaine is incredibly expensive in New Zealand. And so, I think the big thing is that for most people, actually, the best thing is distraction. And if you talk to someone whilst you're putting in an IUC and you're confident and you're distracting them, and so I put mine in a bus, right, and I've got a little window and I'm like, oh, what are the clouds like? And they're like, there's no clouds, there's an aeroplane. And I'm constantly asking you what's out the window, and then they go, so can you gonna tell me when it's bad? And I was like, well, I'm finished. And it's the distraction that makes it okay. From a personal standpoint, having had 5 marinas and one of them having been put in postmenopausal, which was by far the most excruciating of them all, I quite happily wanted to kick my gynecologist in the head. But actually, it was fine. And that was because I knew that's what it was going to be like. So the other aspect is about really, really informing people so that they don't get any nasty surprises. And if they know what's coming, then they cope with it really, really well. So in answer, there's not a lot of evidence for it. I'm not saying don't do it. I do sometimes. And I think paracervical blocks are probably helpful for people with cervical shock, as in who you think are going to have, and particularly that person, like I get referred the person who has had cervical shock before, and can I please put their IUD in, or the person who can't get their IUD out and can't get into the DHB to get their IUD out, and I'm ended up sticking some polyp forceps up into the uterus to pull it out because it's got no strings. I tend to still these days use lignocaine just because it's cheap and cheerful.
What are the IUD expulsion rates like? And if someone's previously had an expulsion, are they more likely to have another one?
So we quote 5% expulsion rate. There's not good data to. We used to say that it would be higher risk in nullips, but in actual fact, there's not good data to support that at all. Most of it occurs early, but some of it can occur really late. So in the adolescent study that I did, looking at New Zealand, we had people having partial expulsions out to 5 years after their insertion. So it can happen at any time. I'll usually try twice, is what I say. So I'll try once. If they expel it, if I can, I'll get a scan to make sure there isn't a uterine anomaly, because we know that increases the risk. But with a normal uterus, then I'll put it in. But if they expel it twice, then I'm like, nah, this isn't going to stay in, and I'm not going to try again for you. But I don't think there's an awful lot of evidence out there, just because there isn't a lot of data on it.
How long should we wait after treating a PID or STI before we insert an IUD?
So an STI until you've cleared it. PID, I would really want to make sure that you haven't got a inflammatory, so that the person is fully cured, and I might well give that a good 6 weeks for PID before I put, and that's partly because I don't want to cause a flare of their PID, and particularly from a fertility standpoint, if they're still wanting fertility. But it's partly because if they've got that pro-inflammatory response, they'll actually find it quite uncomfortable as well. So I really want everything to die down. So you examine them. If they're tender, then I wouldn't do it. And if they're not tender, then I would.
What would be the youngest safest age for a combined pill?
The youngest age, was that? There's a lot of debate in this area. So it's not age, it's puberty, and you need to have gone through puberty. And what you mustn't do is you mustn't give estrogen to someone who hasn't fused their epiphyseal plates because you're going to make them short. So that's the big thing that you need to look at.
Any further information about appropriate contraception for transgender males?
Yes, so in terms of it's a really difficult area to sort of talk about without talking to the person, because each individual often feels very impassioned about what they want and what they would find acceptable. So, for instance, an IUS in some ways sounds like the most logical and sensible thing to do, but for some people will be completely unacceptable. They just won't find that an option that they want to consider. And that's because it involves an intrauterine insertion, it involves an examination, it involves them thinking about the strings, and for them that's just not something that they want to consider. Again, for others, Jadal is not going to be something that they'll consider because it is considered female, and you know, the nature of it is visible, and it is associated with female, so therefore some people will find that completely unacceptable. You don't have to put it in the arm, so you know, you can put Jadal anywhere subdermally. So there's no reason why you couldn't put it somewhere else, and that might make a difference for them, because you know, we know that this is contraceptive rods. So that's something that you can talk about with them. You've got to be aware how you're doing it and where you're doing it, and that you're not going to, you know, if you go too deep, you're not going to cause any problems, because you don't go too deep is the point. You want effective contraception because of the testosterone, which effectively acts as a teratogen, and so that's where the problem then lies when you start going down the pill standpoint, and particularly progesterone only. And so, you know, the advantage of Cerazette would be that you've got that 12-hour window period, and it might be considered more acceptable. As a general rule, estrogen is not going to be something that they're going to want to consider at all. So really it is come down to talk to the individual, talk about for them, where are they at in their transition, is important, and what for them is something that they would consider acceptable and feel comfortable with.
Someone has said that if you're giving the emergency contraceptive pill, especially if it's a little longer after they've had unprotected sex, can giving Depo at the same time increase the efficacy of the emergency pill?
So the problem with that is you're then giving Depo to someone who might be pregnant, and it's not been used in that manner. So I don't think we have any data on it, is the answer. So this always becomes the issue of what do you do with emergency contraceptives, and do you provide them with other contraception at the same time, which is really important. And so there is guidance in the contraception guidelines around that. The worst thing you want to do is have someone get pregnant because not of this unprotected sex, but the next lot of unprotected sex that they have because you didn't provide them with contraception. And we know that contraception fails, and most contraception doesn't have adverse outcomes on pregnancy. They're doing a study looking at Jadal insertion at 36 weeks of pregnancy in Australia, or well, it wouldn't be Jadal, it would be Implanon. So, you know, we've got to remember that hormones in pregnancy are normal. So there's a big lot of discussion there of what the right thing to do is, but I think probably the answer from a Depo standpoint is we don't have data on Depo as a emergency contraceptive.
Mm-hmm. Would you remove a Jadal and put one back on the same day in the same place?
Yes. All the time. I used to put them in the other arm, and now I'm like, why did I do that? I don't know, but I did. I was just put them in the other arm. I don't know.
One scar.
I did. It wasn't. Well, I trained with Norplant, which was 5, so you had so much bruising on one side you didn't want to consider putting them back in again. But yeah, no, I'll put them back in take them out and put them back in the same side. But I talked to the person and asked them what they want.
Any evidence for the rate of increase of ovarian cysts with a Mirena?
Yes, so any progesterogenic only contraceptive is going to reduce. So it's not ovarian cysts; it's unruptured follicles. And yes, absolutely. So, but that's all effective progesterogenic contraceptives, and that's one of the problems. So people who get torsions, that's one of the group of people, if they've had an ovarian torsion, you really don't want them to be ovulating, because you want to reduce the size of that ovary, and so you want to think about something that's going to stop them ovulating. So then you've got Depo and the combined pill really is your options.
Probably just time for a couple more. If you're unable to remove a Jadal rod, would you refer for ultrasound located but under ACC? Do you know if we can get ACC?
Yes, ACC for deep insertion of Jadals. The problem is that a lot of the ACC covered, so it's generally covered without a problem, but the amount that they pay doesn't necessarily cover the cost under ultrasound guidance by an interventional radiologist. And so that's where we end up with a problem in the private system, and where people actually end up having to go through public and interventional radiology there, because they can't afford the co-payment.
Any thoughts on managing actinomyces with an IUCD?
So fortunately, it's rare. Most actinomycosis that you find with an IUD is not an actinomycosis infection. It is actinomycosis that is incidentally found. And if they're not symptomatic, you don't need to treat it. So if you find actinomycosis on a smear in someone who's not symptomatic, you don't need to treat it. If you find someone who's actually got actinomycosis, and I have seen one person who I think has had that diagnosis. I've still not confirmed it, but I think that was the diagnosis. And frankly, I looked at their cervix and I thought they had cancer. It was very odd looking, and they had a history consistent with pelvic inflammatory disease. Then it is a prolonged course of amoxicillin, and it should be managed with consultation with the infectious diseases team.
Someone mentioned at a conference some years ago that a few doses of Depo prior to implant insertion would help with erratic bleeding.
So the data on erratic bleeding with Jadal, apart from the study that I talked about post combined pill, shows that Jadal's really unpredictable with its bleeding in terms of, so the reality is that sometimes it's not what your bleeding pattern is, not what your bleeding pattern is. So, with Mirena, it's crappy for 3 months, maybe up to 6, and it gets better and better, and then you stabilize into whatever your pattern is. With Jadal, it's all over the place. It can be all over the place. It can be great the first year, it can be awful the second year, and then it can be fantastic the third year. And we don't really understand why. And so it's very difficult then to say if something preceding it actually impacted on that, because we know there's a variation over time with it.
And this is probably a nice one to end on. Where are we at with male hormonal contraception?
Not my area of expertise, but I think fundamentally the problem we've got with male contraception is the lack of willingness to accept the side effect profile. So when you look at some of the work that's been done in terms of male contraceptive pills, the side effect profiles are not all that different to the female contraceptive pill side effect profiles, but they're considered unacceptable and they have not been considered safe to go to market. And then the other thing is that, the reality is they're not the person who gets pregnant, and so they're not trusted. But of course, from a male standpoint, having that control yourself is very valid, and we know that there are lots of men who will choose to have vasectomies because of that. And vasectomy is a fantastic form of contraception. It's highly efficacious and works really well with relatively low side effects. Unfortunately, not publicly funded. in New Zealand. So, you know, we're still really stuck with the best form of contraception, vasectomy, and the worst form of contraception, condoms and withdrawal, and there's not anything in between at the moment.
I might just sneak one more question, and if that's okay, because I've had it a couple of times. Someone who has had focal migraines as teenagers, not had them again for many, many years, would the combined pill still be a contraindication?
Yeah, it is. And that's a really common story, because people will often get focal migraines, well, get migraines as teenagers and then get them again around menopause, and not have them in between times. But any focal migraine is still a MEC4.
Okay, we might finish up there. So thank you so much for joining us tonight. And just a reminder to viewers that this will be online on the Goodfellow website tomorrow, along with a list of any relevant resources. Have a lovely night, everyone, and thank you so much, Helen, for joining us.
Thank you very much.